Hello, my dear friends. Welcome to the today's daily dose. I'm myself Dr. Rajesh Gubba. I'm a cardiologist and I'm also the mentor for teaching general medicine for exams like NEET PG, PGI, AIIMS, and as well as JIPMA. So, as the part of today's daily dose, let me just come up with a very important clinical scenario. So, I have a 76-year-old male brought to the accident and emergency department after collapsing at the home. He has recovered within minutes and is fully alert and oriented. And he says this is the first such episode that he has experienced, but describes some increasing shortness of breath in the previous 6 months and brief episodes of even chest pain as well. So, like, what are all the clinical points here? The patient had a collapse. The patient has shortness of breath on exertion. The patient is having chest discomfort. So, these are the three important clinical points. And you take the blood pressure, it is 115 by 88 millimeters of mercury. And there are few rolls at both the bases. Right? So, there is bilateral basal crepitations. ECG, it is very much suggestive of left ventricular hypertrophy. Which of the following might you expect to find on auscultation? Now, so we will just summarize the entire clinical points. The individual had a collapse, and what is the age of the individual? The age of the individual is 76 years. And exertional dyspnea, that is shortness of breath, and the individual is also having chest discomfort. Right, and blood pressure is how much? 115 by 88. So the pulse pressure is like more or less like narrow pulse pressure, right? And the bilateral basal crepitations are there on the auscultation. ECG is very much suggestive of left ventricular hypertrophy. So you see now, elderly male presenting with syncopal attack along with exertional breathlessness and chest discomfort, more or less narrow pulse pressure with ECG suggestive of like left ventricular hypertrophy. So what is that which should come to your mind? Remember, the individual is having collapse because of decreased cerebral perfusion. Now, elderly male with the underlying clinical scenario, why do you think he will have that collapse is because he is having an underlying valvular lesion, that is your aortic stenosis. Right, underlying valvular lesion, that is aortic stenosis. Now, in aortic stenosis, there is a triad. What is a triad? Number one, presence of the exertional breathlessness. Next, chest pain. Then, presence of syncopal attack. This is a triad in the aortic stenosis. Now, if you take the clinical scenario of the patient, all these three particular clinical manifestations are there. Along with that, ECG is also showing left ventricular hypertrophy. See, in patients with aortic stenosis, what exactly will happen is there is increased afterload on the left ventricle. Because of increased afterload on the left ventricle, there will be left ventricular hypertrophy. And how can you say that there is left ventricular hypertrophy in the patient? That is being said by your left ventricle ECG showing left ventricular hypertrophy. I'll show you the criteria of left ventricular hypertrophy in the ECG. Now, what will be the clinical manifestation? Now, you take options. Mid-diastolic murmur, which is present at the apex. So, where do you get this particular mid-diastolic murmur? Mid-diastolic murmur at the apex, you will get this in patients with the mitral stenosis. So, your first option is ruled out. Then, crescenting systolic murmur, which is best heard at the right sternal edge. So this is the murmur like what you will have in patients with the aortic stenosis. In aortic stenosis, it is actually the mid-systolic murmur, or we call it as ejection systolic murmur. So it is this ejection systolic murmur which is heard at the right sternal edge, which is very much suggestive of aortic stenosis. Whereas you take the third option, diastolic murmur, best heard at the left sternal edge. Right, diastolic murmur in the left sternal edge. Like in which clinical scenario you can have that? You will have this in patients with the pulmonary regurgitation. In pulmonary regurgitation, you can have early diastolic murmur in the left sternal edge, and that too in the second left intercostal space. That's a very important point. Then you take the pansystolic murmur at the apex. So the pansystolic murmur at the apex, it is seen in patients with the mitral regurgitation, right? And pansystolic murmur best heard at the left sternal edge, that is heard in patients with tricuspid regurgitation, right? So murmurs is one of the very important topic wherein you need to differentiate what is the underlying clinical scenario, right? So I have also done a very important session on the cardiac murmurs. So you can watch that particular session on the cardiac murmurs on the same channel, right? So now in this particular patient, the patient is having aortic stenosis. So what do you think is the correct answer now? It is a crescendo systolic murmur which is best heard at the right sternal edge. Now you take the ECG suggestive of your left ventricular hypertrophy. The name of that particular criteria is your Sokolov-Lyon criteria. It is basically the voltage criteria. So what does this Sokolov-Lyon criteria tells you to call it as left ventricular hypertrophy is that, like, you take the ECG leads. So this is your V1, this is your V2, this is V3, this is V4, V5, and then V6. The formula to consider the Sokolov-Lyon criteria positive is that SV1 plus RV6. If it is more than 35, then we can consider that the patient is having left ventricular hypertrophy. Now you take in this, so SV1 is how much? So what is this SV1? That is S wave in V1. What is RV6? It is R wave in V6. Okay, so SV1 is 16 plus RV6 is how much? 32. So that becomes how much? That becomes around 48. So which is very much suggestive of the Sokolov-Lyon criteria to be positive. And that is very much suggestive of what is called left ventricular hypertrophy, right? So this is the criteria for your LVH. And another important voltage criteria for the LVH is that in AVL, in late AVL, if the QRS complex, right, if it is more than 11 mm, then it is also suggestive of left ventricular hypertrophy. And in left ventricular hypertrophy, not only the large complexes you will have what is called strain pattern. What is that strain pattern? That is ST depression. You see here, this is ST depression. Along with that, the T-wave inversion. So ST segment depression and as well as asymmetric T-wave inversion. Right? Asymmetric T-wave inversion is very much suggestive of left ventricular hypertrophy. So this is the ECG finding in patients with the left ventricular hypertrophy. So going back to the question, this particular patient has the aortic stenosis and the murmur is crescendo systolic murmur which is best heard at the right sternal edge. So I hope you might have liked this particular short video on this aortic stenosis. So please do follow us on the daily dose wherein you will get the daily updates. Thank you very much.